This video is meant for informational and educational purposes only and should not be understood as medical advice under any circumstances. Our agenda for today is that we will first start with a review of the basic physiology, followed by definition and causes of hyperkalemia. We'll then move on to the diagnostic evaluation and finally treatment. I find it helpful to start by reviewing the basic physiology of how potassium homeostasis is maintained, because this can help us make sense of how we are going to work up and treat the high potassium. Here's a very oversimplified view. Your body's potassium all comes from what you ingest. It is then mostly stored inside the cells. In fact, 99% of your total body potassium is in the cells. It is maintained by two channels, the sodium-potassium ATPase, as well as a hydrogen-potassium cation exchange. Insulin, beta-2 agonists, and aldosterone in the kidneys all stimulate the sodium-potassium ATPase, and excess alkalosis will stimulate the hydrogen-potassium exchange. Potassium helps to determine the resting membrane potential in your cells, including your heart and skeletal muscles, which is one of the reasons that severe derangements in potassium can lead to arrhythmias or muscle weakness. Lastly, potassium leaves your body through the kidneys and a little bit through the GI tract. Over 90% is left through the kidneys and less than 10% through the GI tract. This ratio may vary depending on the person. For example, in patients who are nearing end-stage renal disease, it is thought that the GI tract has a greater contribution. In certain disease states, such as severe diarrhea, however, you can lose a lot of potassium to the GI tract. It is helpful to think about this schema when thinking about causes of hyperkalemia and also how we can treat it. Next, moving on to definition and causes of hyperkalemia. You will see in the left-hand corner of your screen how to classify hyperkalemia into mild, moderate, or severe. These definitions might vary depending on where you look, but these are a good starting point. Some experts don't define hyperkalemia as severe until a patient gets into the 7 or 8 range, but I like to use a more conservative definition of 6.5. Not everyone uses a definition of EKG changes to define severe hyperkalemia, but again, I tend to operate on the more conservative side. We will discuss what these EKG changes look like in just a bit. But before we even get to the causes of hyperkalemia, we need to first make sure that this is true hyperkalemia and not pseudo-hyperkalemia. In other words, a falsely elevated potassium level. As we already know, 99% of your body's potassium is stored intracellularly. So if anything causes cells to become damaged during or after the blood draw process, potassium can spill out of these cells and cause an artificially high value. By far, the most common example of this is a hemolyzed specimen. In other words, something happens during the blood draw process that causes trauma to the red blood cells. These red blood cells break down and spill out all of their potassium into the phlebotomy tube. The result is a very high potassium that is not reflective of your body's actual level. So what can cause a hemolyzed specimen? Sometimes something as simple as prolonged fist clenching can do it, or prolonged tourniquet use, or even a difficult stick using a small needle that leads to shearing. Oftentimes the lab will report whether or not a specimen is hemolyzed, but when in doubt, you should check to be extra sure before you go chasing down an artificially high level. There are two other rare causes of pseudo-hyperkalemia. One is profound leukocytosis, and the other is profound thrombocytosis. Leukemic cells can be very fragile and break apart in the phlebotomy tube after being drawn, causing potassium to spill out. If you suspect this, you should call your lab and ask about ways to negate this effect. For example, some recommend taking an arterial sample or even walking the specimen down to the lab instead of using the pneumatic tube system, which may cause cells to break apart. In thrombocytosis, clotting in the tube can lead to potassium being released. Again, in this situation, you should call your lab to figure out the best way to discern the true potassium level. So now that we have confirmed that this is not pseudo-hyperkalemia, you can think of what might cause a truly elevated potassium level in the body. I like to think about this in 3 buckets. 1, increased potassium load. 2, cell breakdown and transcellular shift. And 3, decreased renal excretion. First, starting with increased potassium load. This usually means a high potassium diet. Think of bananas, potatoes, other fruits and vegetables. Even salt substitute can be a sneaky cause of high potassium. Patients who try to follow a low salt diet might use a salt substitute which uses potassium chloride instead of sodium chloride. So this is something to be aware of. In the inpatient setting, it is also wise to look over TPN or tube feed formulation if they are on supplemental nutrition and involve your dietitian. Importantly, increased potassium load is often not enough just by itself to cause hyperkalemia. Your body is actually pretty good at regulating the potassium, and usually you have to have increased potassium load plus something else going on. This brings us to our second bucket, cell breakdown and transcellular shift. Anything that can cause cells to break down can lead to potassium spilling out of the cells. This could include things like rhabdomyolysis, tumor lysis syndrome, and systemic hemolysis. Certain conditions can also cause a shift of potassium for reasons we discussed earlier. Going back to our schematic, you will see that things like insulin, beta-2 agonists, aldosterone, and alkalosis will all help to keep potassium in the cells by stimulating the various channels. However, if you have the opposite, such as low insulin, beta blockers, or hypoaldosteronism, the potassium can actually shift out of the cells. The clinical conditions that would produce this include things like hyperglycemia and acidosis. I bolded hyperglycemia because this is actually an incredibly common contributor to high potassium values in the inpatient setting. Certain medications are reported to lead to potassium shift, including the ones listed here. Quite honestly, I have never seen these as particular medications as a profound contributor, but it would be important to review medications with your pharmacist, especially if a patient has refractory hyperkalemia. Lastly, decreased renal excretion. This can be caused, unsurprisingly, by AKI or CKD. Urinary tract obstruction can also cause this, independent of the degree of AKI. It's important to think about medications as well, like ACE inhibitors, ARBs, or trimethoprim sulfamethoxazole being common offenders. Hypoaldosteronism can also lead to hyperkalemia. Remember, aldosterone stimulates that sodium-potassium ATPase that we discussed earlier. One often overlooked cause of hypoaldosteronism is type 4 RTAs. I used to think of RTAs as being incredibly rare, but they actually aren't that uncommon, especially in type 2 diabetics with long-standing nephropathy. Moving on to diagnostic evaluation. All patients with hyperkalemia should have a very basic workup. This includes a CBC and a BMP. The CBC will alert you if there are any significant hematologic abnormalities that might lead to pseudohyperkalemia and can also hint if systemic hemolysis might be an etiology. The BMP, or basic metabolic panel, is probably what alerted you to hyperkalemia in the first place, but it can also provide other clues for what might be going on. For example, the bicarbonate level can give you a hint at the acid-base status of the patient. The creatinine will alert you to any kidney dysfunction, and the glucose will obviously let you know if hyperglycemia may be contributing. Patients should also have a somewhat real-time point of care glucose as well, given that you may end up treating them with insulin, as we'll get to in a little bit. Lastly, anyone with a potassium of 6 or greater should have an EKG. They should also be placed on telemetry regardless of the EKG changes. Remember that hyperkalemia can lead to fatal arrhythmias. This is independent of whether or not you happen to capture EKG changes, so you should have a low threshold to place the patient on telemetry if the potassium is over 6 or according to your institutional guidelines. So what are the EKG changes? Somebody once told me to imagine pulling up on the T wave, and these are the changes that you will expect to see in hyperkalemia. Importantly, these EKG changes are not very sensitive and only moderately specific for hyperkalemia. First, you might see a peaked T wave. This can be so tall that it may even look like the QRS complex. Next, the PR interval might become prolonged, and you may even lose your P wave altogether. You can also see a widening of the QRS, and finally, what you wish to avoid is a sine wave pattern in degeneration into VFib. Sometimes these changes can be subtle, and so it's most helpful when a patient has a prior EKG to compare waveform morphologies and interval length. To summarize so far, we discussed the basic physiology, including the importance of that sodium-potassium ATPase in keeping potassium inside the cells. We next talked about the definitions and causes of hyperkalemia and the importance of making sure that this doesn't actually represent pseudohyperkalemia, the most common cause of which is a hemolyzed specimen. Next, we talked about the diagnostic evaluation that all patients with hyperkalemia should get, including a CBC, a basic metabolic panel, point of care glucose, and EKG. Now that we discussed that, let's move on to treatment. Thinking about treatment of acute hyperkalemia, I like to think of this as going from quickest acting to longer acting. There are 3 general steps to treating hyperkalemia. First, stabilize the cardiac membranes. Next, try to temporize by shifting the potassium into the cells. Even if shifted potassium was not the cause of hyperkalemia, you can temporarily fix the problem by transiently moving the potassium back into the cells. Finally, as a more long-term measure, actually try to eliminate excess potassium from the body. I was once taught a very helpful mnemonic when I was a medical student, and that is C big K die. I wish I remembered who taught me this, as I would give them credit. I like this mnemonic because it's easy to remember and actually goes in order of how you think about treating. Starting with C. This is calcium, and it works to stabilize the cardiac membranes. Think calcium, cardiac. It actually does nothing to lower the serum potassium. You can either give calcium gluconate or calcium chloride. However, calcium chloride should be given centrally since there is a risk of tissue necrosis if given peripherally. You should give this if you see EKG changes, but I also give calcium if the potassium is very elevated, even without EKG changes, because remember, these changes are not very sensitive or specific. I use 6.5 as my personal cutoff, but this may be more conservative than most. You do not need to give calcium if the potassium is only mildly elevated and there are no EKG changes present. Importantly, after you give calcium, you want to recheck that EKG if you had seen any changes to begin with, such as peak T waves or a widened QRS. If those changes don't resolve, you can repeat the dose of calcium. Next, for temporizing the shift of potassium back into the cells. Typically, these measures take on the range of minutes to hours. And thinking back to our basic physiology, we can use this to our advantage when we think about our treatment options. We'll start with the B for beta-2 agonist. Typically, this is an albuterol nebulizer of 10 to 20 milligrams given over 10 minutes. Please note the dose here because this is very high compared to what you would standardly give for a patient with a COPD or asthma exacerbation, for example. The typical dose is 2.5 milligrams, so we are giving 4 to 8 times your normal dose. Bicarbonate is also a possible treatment to help shift potassium back into cells. However, the evidence here is much more limited. I don't typically give bicarb unless the patient has a concomitant metabolic acidosis. Next, insulin plus glucose can be given. The insulin draws that potassium back into the cells, and you give the glucose in order to prevent hypoglycemia. Importantly, if they have an elevated blood sugar to begin with, you don't need to give the glucose. I put in some typical dosing here for somebody with a normal blood sugar, and that's 10 units of IV regular insulin and an amp of D50. However, you would really base this on what the blood sugar is at the time. It's important to keep an eye on the blood sugar after giving the insulin, as these patients are at very high risk of hypoglycemia. So I would recommend monitoring glucose hourly for at least the next several hours. Next, moving on to ways to decrease our total body potassium. First, Kayexalate, also known generically as sodium polystyrene sulfate. This is a medication you can give orally and will stimulate the patient to have a bowel movement. In general, this is very safe. However, you may recall that there is a risk of bowel necrosis. This is quite rare. However, it is wise to still avoid using Kayexalate in patients with a history of bowel surgery, current or prior bowel obstructions, or other types of gut compromise. There are newer binding agents available, including the ones listed here. These are effective, they have lots of support from clinical trials, and they're very well tolerated compared to Kayexalate. These will probably become much more commonplace soon. So this is how we eliminate the potassium through the gut, but we can also help eliminate it through the kidneys with diuretics. I would give a loop diuretic here, such as Lasix, especially if the patient is volume overloaded. The dose of your diuretic will really depend on what their kidney function is doing and the other clinical circumstances. Even if the patient is euvolemic, you can still give diuresis and also give back a little bit of normal saline to help prevent dehydration. And always remember to put the patient on a low potassium diet and discontinue offending medications while you are fixing their potassium. One quick note about the diet, a low potassium diet actually eliminates a lot of healthy fruits and vegetables from the diet. So if you are able to correct the underlying etiology, I probably wouldn't be too stringent with a low K diet. This is something I would have the dietitian consult on and meet with the patient about prior to discharge. Also, in regards to the medications, ACE inhibitors and ARBs can commonly lead to hyperkalemia. However, they also provide a very significant mortality benefit in certain populations, such as those with heart failure with reduced ejection fraction. So, while it is wise to stop these medications when somebody has significant hyperkalemia, it is also prudent to always reassess if these medications can be safely restarted, especially if the other underlying etiologies of hyperkalemia have been reversed. At the very least, include this in your discharge summary from the hospital so that this can be on the radar of the patient's PCP in their post-hospital follow-up. Finally, dialysis is also a strategy here, especially if the patient has acute refractory hyperkalemia in the setting of renal failure or is anuric. Thank you so much for watching this video. I know your time is incredibly valuable and really appreciate you taking the time to watch this. If you have any questions, comments, or suggestions, please feel free to reach out to me at the email address listed here. I will also remind you to please download our one sheet on imresidencyprep.com. This is an outline that follows the format of our talk so that you can keep track of all of the clinical information and pearls in one convenient sheet. Thank you again for joining in on our IM Residency Prep series.